Hi, everybody, and welcome to today's episode of Meet the Researcher. I'm excited today to welcome Dr. Mark Ball. Dr. Ball is an attending surgeon in the urologic oncology branch of the National Cancer Institute at NIH. He also serves as the Associate Program Director of the Urologic Oncology Fellowship Program. He specializes in the surgical treatment of kidney and adrenal tumors and performs robotic, laparoscopic, and open surgery. He has a particular expertise in robotic partial nephrectomy and robotic partial adrenalectomy for hereditary cancer syndromes and has removed over 500 kidney tumors during partial nephrectomy procedures. He is highly experienced in reoperative surgery in patients with a history of prior surgeries and in patients with multiple tumors. Dr. Ball's research focuses on how tumor genetics translates into clinical behavior. He has authored over 90 peer-reviewed manuscripts, multiple book chapters, and regularly presents his work at national and international meetings. Dr. Ball, thank you for joining us.
Well, thank you so much, Josh, and to the VHL Alliance for having me today. Really honored to be able to talk with you and share with you what we're doing at the NIH and at the National Cancer Institute, and particularly how what we do to make VHL kidney surgery safer. So I'm going to share my screen. I've got some slides on the research we do. And I've called this talk, When and How We Choose to Operate on Kidney Tumors in Patients with VHL. So I know you've heard from other researchers, and many of us are in the same boat, that we are really surgeons and scientists, or clinicians and scientists. And there's not really a separation in what we do. Most of you patients with VHL that I've met, I've probably met in clinic. And you can see here with the clinic team and a patient interaction. But where I spend most of my time is in the operating room. And at the NIH, you've probably not really seen kind of behind the curtain here like this, but what we do is we treat the operating room really as an extension of the lab. And what I mean by that is every patient that comes in, we have MRIs or CT scans, and we've numbered every tumor that we can see on the scans. And when we remove those, we immediately look at them, both with our pathologist to make sure that we've gotten everything that we intend to, but we also have our lab team ready to analyze the tissue that comes out of a patient's body, so we're able to make scientific advances and in both learning more about the pathways that cause VHL, but also hopefully for therapies that can reduce the needs for surgery in the future. And so as a surgeon scientist, what we do is we rely on clinical observations, and then we analyze those observations, and we refine those techniques and take those back to the lab and to the operating room. And when Dr. Ned Sharpless, who is the director of the NCI, came to listen to one of our tumor board talks and heard us talking about VHL in particular, he said, what it sounds like that your team does is you perform precision surgery based on genetics and based on all of the personalized factors that we see in each patient. And I believe that is what we do. So I want to give you a few examples of observations that we've had that have led us to perform surgery safer. And I came across this quote a few years ago, and I think it particularly applies to VHL, and that's extreme remedies are very appropriate for extreme diseases. And we certainly see a wide spectrum of manifestations of VHL, and some of them do require us to do extreme surgeries or extreme therapies that I hope we will be able to do things in a less extreme manner as we get better with new therapies. So one of the challenges for dealing with doing surgery in someone with a hereditary kidney cancer is multiple tumors requiring multiple operations. And so the question is, when do we intervene and how do we intervene to prevent metastatic disease, preserve kidney function, and maintain quality of life? And so it's really about finding a balance. If we think historically, what was done decades ago is many patients would have bilateral radical nephrectomies, remove both kidneys and go on to dialysis. And the reason for that is it protected from metastasis, and it obviated the need for repeat surgeries, but obviously a huge impact on quality of life. On the other side of the spectrum, we could do surgery every time we see a new tumor that comes up in the kidney or the adrenal gland. And that could require dozens of surgeries over the years. And we know that the more times we go in, that is potentially associated with increased risk of complications. So how do we know when tumors are safe to watch? And when I came to the NIH initially as a fellow, I really had a few questions. One was, how do we predict how tumors grow? The next was, what are the changes in bigger tumors that make them more likely to metastasize? And the third was, how do we make surgery safer? So I'm going to go through each one of those a little bit. This was a paper that we just published in the Journal of Clinical Oncology. It came out just this month. And it was looking at several different hereditary cancer syndromes. And you can see VHL in the top right corner. And what we noticed over the years is that there were differences in how tumors grew. And so we looked at several syndromes, but VHL made up the majority of our patients. And we looked at 435 tumors, and 286 of those were from patients with VHL. And we found that on average, VHL tumors grew between 3 and 4 millimeters a year. And that really didn't differ based on if the patient was a man or a woman. We'll come back to age. Based on BMI, body weight had no impact. The size of the tumor to start with did not have an impact, and whether or not the patient was a smoker. If we also looked at the types of mutations they had or where the mutations occurred within the VHL gene, none of those things really made a difference in growth. But the one thing that we did note is that younger patients have faster growing tumors than older patients. And if you look in our youngest sort of 25% of patients in this study, which were patients that were 42 or less, those tumors grew at half a centimeter a year versus the older patients, which grew at 0.3 centimeters per year. So why is that? Is there a hormonal influence? We don't know, but that's one of the things we are actively investigating now. But it was certainly an interesting observation. And so knowing how fast tumors grow allows us to predict future size, and hopefully that can help us plan for future clinic appointments and for future surgeries. So the next question we have is, what is the appropriate size to intervene? And predating me at the NIH, there was sort of a rule of thumb that was when a tumor gets to be 3 centimeters, that is when we should go and operate. And that was really based on a few observations from a handful of patients, but it turns out that those observations were spot on because we've now been able to extrapolate that to many, many patients. And so on the left is an example of a patient that we would see often at the NIH who have multiple tumors, and they're approaching 3 centimeters. And based on the scan on the left, that's when I would recommend surgery. But we also see patients who, for whatever reason, have not been managed by this 3 centimeter guideline. Perhaps they have a new diagnosis. Maybe they were they're new patient to us, or for whatever reason, follow-up didn't happen, and it's been a number of years. But that gives us a chance to compare the rates of metastatic disease based on a tumor size. And what we found was this, that in patients whose largest tumor was 3 centimeters or less, that no patient has ever had a tumor that spread, which is quite remarkable for a number that was initially based on sort of limited experience, now based on hundreds of patients. But as tumors get bigger, the chance for spreading obviously increases. So if you look on this table on the left, between 3 and 4 centimeters, the risk of spread, still very low, but around 3%. between 4 and 5 centimeters, upwards of 13%. Between 5 and 6 centimeters, 26%. 6 to 7, 50%, and greater than 7, 60%. So that's really underscores, why we advocate for intervening early at that 3 centimeter mark. The graph in the middle shows the difference in living without metastasis over the years. And the top sort of straight line in red, these are the 100% of patients that remain metastasis-free when their largest tumor was 3 centimeters or less. And you can see with time, for patients with larger tumors, the risk does go up. So that certainly informs how we think about planning for surgery and planning for follow-up of patients that we see at the NCI. So just to summarize those last couple of slides, intervening at 3 centimeters is a safe threshold to the risk of kidney tumor spreading. Now, moving on to the last part here is making surgeries safer. And these are 3 of my fellows that some of you may have met in clinics, Dr. Chalfin, Dr. Telfer, and Dr. Gurham. And they had back-to-back posters this year in San Francisco before COVID-19, and our genitourinary symposium of the American Society of Clinical Oncology on making surgery safer for patients who have either multiple tumors or reoperative surgery. So I want to share a little bit of that work. So the first question is, how do you compare the complexity of a case? Not every surgery comes with the same risk, and it really depends on, just like real estate, location, location, location. And so where a tumor is within the kidney can make it more or less complex. And there's a score that was developed several years ago by researchers at Fox Chase called the renal nephrometry score, based on the size and location of a tumor. But this type of scoring system is based on patients with 1 tumor who've never had surgery before, so not necessarily applicable to patients with VHL. So what we did was try to extrapolate this type of scoring system to patients with VHL, and we made what's called a multiplex score, which is the number of low-risk tumors based on size and location, plus 2 times the number of intermediate-risk tumors, plus 4 times the number of high-risk tumors. And so for the patient on the left, they had a multiplex score of 2 because they had 2 small tumors on the outer surface of the kidney, something we would consider not very complex, versus on the right, a patient who had multiple tumors going quite deep in the kidney. And what we found is that this score associated well with predicting complications, predicting bleeding during a case, and predicting conversion to open surgery if we start robotically. So hopefully this type of scoring system can help us better counsel you before surgery on what we think the outcomes may be. The next study, this was by Dr. Telfer, and this was looking is there a learning curve among surgeons who perform these types of surgeries for patients with VHL or for patients with multiple tumors. And this is a little bit biased because these were all 3 NCI surgeons, myself, Adam Metwally, and Gennady Bratislavsky, and looking at our first 100 cases each. And if these kind of look like random scatters of dots, you'd be reading that correctly, because we didn't really see any trends in taking out a certain number of tumors and the time it takes in the OR or blood loss associated with cases. And how we interpreted this is that the 3 surgeons included here all did fellowships at the NIH NCI and seeing many, many patients with VHL, and that there was no learning curve effect in our group. And so, we would like to expand this work to include surgeons at other centers to see if there is sort of a number that you should be looking for when you're choosing a surgeon. How many cases have you done to make sure that surgery is going to go safely? And then last section here for the kidney surgery section, this is the surgical approach for redo surgery. Now, traditionally, reoperative surgery was always done open with open incisions. We and others began approaching more and more complex kidney tumors robotically, including going in 2, 3, or 4 times, even after previous open surgeries. And I had the idea to look at this because a couple of years ago at a national meeting, a picture went up of a scan of a patient with VHL that had 5 or 6 tumors throughout the kidney, and they polled the surgeons in the audience how many would do this surgery open versus robotically, and 95% of the hands went up to do open surgery. So I said, well, maybe we're not thinking about this right. Let's look at the data. So traditionally, open surgery, reoperative surgery, you might end up with something like this. This patient has had multiple incisions in the middle here, the midline, an upper incision, a lower incision, one in the back. And we can obviously, if we can go in robotically, it certainly can be a faster recovery, but how do we do otherwise? And what we found is that actually in terms of complications, that there is not only was there was robotic surgery not worse, it actually seemed to be better. Now, this comes with some caveats. These were highly selected patients, choosing the right technique for the right patient. But what we found was that patients who had robotic surgery after open surgery or robotic surgery after a previous minimally invasive surgery had lower complications than those who had open surgeries in the repeat setting. And so, this just reinforces the idea that we can improve, patient pain, patient recovery without compromising, having complications that, like bleeding after surgery or leakage of urine after surgery. And so just, a quick illustration of the difference, robotic surgery with several small incisions. And when we do open surgery now, we try to make that as minimally invasive as possible too. We do what's called a modified incision now, so we never remove ribs, and we try to make incisions as small as we can. And here is a patient I saw back in post-op, and you can see a nice small incision, just about the size of my 4 fingers here. Last thing I will say before we open it up to questions is looking at outcomes for patients with pheochromocytoma. And this was a paper one of my fellows, Dr. Gamella, wrote with me, where we looked at 125 partial adrenalectomies for patients with feos over the years. And what we see in the bottom left corner is, one, we're doing a lot more robotically here too, almost all robotically now versus early in the experience where it was mostly open or laparoscopic. We're able to preserve the adrenal vein, which just has implications potentially for adrenal function. A lot more now that we're doing things robotically. That's what this yellow line shows. And out of those 124 surgeries, 10 patients did require steroids after surgery. All those patients had only one adrenal gland at the time of surgery. So if we're able to preserve both adrenal glands by doing partials on both sides, most patients can live steroid-free. And 17 patients did develop new adrenal lesions later on, but most of those could be managed by watching those with serial images rather than doing immediate surgery. One last thing, and this is just an interesting image, and hopefully shows something about the future of surgery here. This was a patient that came to us who had a large tumor in the kidney that was touching the vein of the kidney. And this is the type of surgery that even just a few years ago would almost be done a total nephrectomy. But what we had the opportunity to do here was use new technology, and that's virtual reality, to model how the tumor would look during surgery. And what we saw I don't know if you can hear me in the video. The area of the tumor that's in contact with the vessels. So everything should be free, and then hopefully we're able to very gently brush away the vessels, take the tumor inflammation. But we were able to manipulate the kidney in virtual reality before surgery and see exactly where the vessels entered, and we were able to save 95% of that kidney during surgery. And so I would just like to say, you know, everything we do is very much a team effort, of course, led by Dr. Linehan. Dr. Srinivasan is a big part of what we do, even on the surgical side. He's a medical oncologist, as you know, but he's really a major part of our team. All of our nurses, our fellows, our residents, our genetics team, our pathologists, our radiologists, all contribute to what we're able to do. So that's my planned slides. I would love to take any questions from the audience.
First of all, Dr. Ball, thank you so much for sharing. That was great. We have quite a few questions for you. First of all, why should people outside of the VHL community support VHL research? What are the implications on the general population?
Oh, fantastic question. One that I hear from patients, also from other people in the urology and the surgery community. I think it has major implications. You know, by studying the VHL pathway, Dr. Linehan and his team found the gene for VHL, found the VHL pathway, but that is the same pathway that is altered in 90% of clear cell kidney tumors in the general population. So the most common type of kidney cancer, the same pathway is responsible for it. And all of the drugs that target metastatic clear cell cancer came from studying that pathway, with you know, plus the immunotherapy drugs. That's a little different. That's not the pathway, but all of the targeted therapies. So it has major implications for understanding kidney cancer in general. And so good question, but we think they go hand in hand.
We're getting lots of questions, Dr. Ball. Here's a great one. Are all kidney tumors considered cancer?
Very, very good question. And, you know, it's not uncommon that I talk to a patient, and maybe they've had surgeries before, and I say, you know, this, and when we take out this tumor, I expect that it will be a kidney cancer. And they say, oh, cancer, I've never had a cancer before, which actually probably isn't true. Most solid VHL tumors are cancer. We're talking 95% plus. Now, sometimes they are mimickers of cancer, but most solid tumors are cancer. That being said, most of them are a low-grade cancer that will not cause problems as long as it's removed before it gets big and has the chance to become a potentially aggressive cancer.
Should patients with known feos have them removed even if they're not active?
These are all outstanding questions. I would say in most circumstances, not necessarily. So if a feo is not active, it can be safely watched, but there are some scenarios where even if it's not active, I would recommend removing. So here are a few examples. If a patient only has one adrenal gland, I don't necessarily want the feo in that one adrenal gland to get bigger and bigger where I might have to sacrifice more normal tissue. So for that patient, I may recommend let's remove it before it has a chance to get active. If a patient is, say they're a young woman of reproductive age and they are thinking about family planning, they have a feo, I don't necessarily want to have a asymptomatic feo in someone who is thinking about becoming pregnant. You know, I would recommend that coming out beforehand, because we would lose a window for several months to intervene. But for most other circumstances, they can be kind of safely watched until they're symptomatic and with no deleterious effects.
Here's a question that we get quite often. In what circumstances should people consider exploring a second opinion and/or treatment at NIH rather than their local hospital?
Um, good question. You know, while we certainly see a lot of patients with VHL and have experience, we do not have a monopoly on knowledge, skill, experience. I wouldn't second guess anyone out there, but there are, in general, I think it's never wrong to think about a second opinion for anything that has implications like a major surgery. And if a patient sees me and wants a second opinion, I'll gladly give you names of people I know and trust to go seek that. No physician should ever be offended that a patient wants to advocate for themselves. Okay. Um, Now, when do I think a second opinion might make more sense than others? Well, if you're hearing about things like total kidney removal or bilateral total kidney removal, I certainly think that deserves a second opinion. Perhaps total adrenal removal too. We in many cases, even in complex cases, we can spare normal function of kidneys or adrenal glands. So I think that could be a time where a second opinion is warranted.
Here are a couple questions about robotic surgery. Do you get the same visualization of the kidney with robotic surgery? Might you find more hidden tumors with open surgery? And then here's the another question is, are there any circumstances in which robotic surgery would be less desirable than other methods?
Hmm. Yeah, I think the differences in robotic surgery and open surgery, um, in terms of visualization, that's not something that I'm concerned about. In fact, I personally think I can see better robotically because it has 10x magnification. So I can certainly see the details of an individual tumor better robotically. Can we find the same number of small kind of hidden tumors? I like to think so. That's not a question I've necessarily looked in the data, but certainly would be answerable. The circumstances, though, that I think robotic surgery is less desirable is if someone has, okay, so let's go back to that scenario of someone who's had multiple prior surgeries. And I said that we can kind of cherry pick, and many people are safe to have a robotic surgery. I think that is true, but in some cases I would hesitate. If someone has multiple prior surgeries on a solitary kidney, I think more often than not that open surgery may be safer depending on the location of the tumor. If the location of the tumor is very close to the blood vessels of the kidney and it's in the reoperative setting, that's another time I think open surgery may make more sense. So really, and I guess to summarize, that would be cases where I feel like the kidney could be threatened to have to take out the whole kidney. Open surgery, we certainly have some maneuvers that aren't available during robotics.
How does best practices change between sporadic versus VHL related kidney tumors?
Yeah, it's in many ways, VHL has been ahead of the curve compared to sporadic. And what I mean by that is, um, for many years, we've been doing active surveillance initially for kidney tumors in patients with VHL, waiting for them to get to that 3 centimeter size. While in this patients with sporadic kidney cancer, many times they would have a small 1.5 centimeter tumor, and there's a rush to go to the OR and take that out immediately. In most circumstances, not 100%, but in most, a patient with a sporadic small kidney tumor, it behaves very similarly. There's low risk until it gets bigger. So I think that sort of the kidney cancer community at large recognizes that a lot more now than maybe in the past, and active surveillance as an initial strategy is certainly more, is gaining a lot more traction.
Uh, Here are two questions that sort of go together. Is there data that indicates that after removal of the RCC tumor, what the average time to recurrence is? And then the follow-up question is, how many times can you remove tumors that keep reappearing on one kidney?
Yeah, the first one is we don't have good data because it's pretty variable. I would say in general, we get a few years, but I've seen patients that have had a repeat surgery 12 months later, and patients who don't need a repeat surgery for 12 years later. It's very variable. That's still one of those kind of unknown questions, something that we're actively trying to answer though. And the second question was remind me again, Josh?
How many times can you remove tumors that are reappearing in one kidney?
Yeah, we have gone in as many as 5 times to the same kidney, at least on a handful of occasions, 4 many times, and 3 numerous times. So 3, 4, 5 is certainly within what we're currently comfortable doing, and there are times that may extend to even more than that, depending again on the location of the tumor and so forth. I think it is the fact that tumors do seem to slow down in growth as patients get older. I think helps the situation that we don't run into too many cases where a 5th or 6th time is required.
And then I'll just leave you with this last question, or sort of a double question. Do you have any updates on the PT2977 trials or any other trials for RCC that seem encouraging? And the follow-up would be, what do you think the future landscape looks like based on current research?
Yeah. So with the current trial, we're obviously still in the accruing data phase, and part of that means that we're a little bit can't discuss openly too much because it's what the goal of that trial is if it's positive is to go forward to look for FDA approval, and so we don't want to bias any results. I would say that from what I hear from not from what I necessarily see from looking at the data, but just from what I hear and what I see on social media is a lot of positive responses, and so I can share back what you all share with me, right? So I'm encouraged by what I hear, and I think that the future of the treatment of VHL is going to rely on a drug kind of in this type of class that can, best case scenario is we get something that can reverse manifestations of VHL, but I think a realistic goal for sure is something that can kind of halt the growth of tumors or stop the growth of new ones. So even if we can't reverse what's already there, if we can stop things from growing, well, geez, we can stop reaching the threshold that we need to do kidney surgery, or if things aren't growing in the CNS, stop when we need to do brain and spine surgery. So I think that is a point that we will get to, and I hope that it's sooner than later. And I think I'm pretty early in my career. I think in my career there's going to be a big difference in where we are now and where we are in a few years.
Well, we could only hope so. And with that hopeful last message, Dr. Ball, I just want to thank you for taking the time today to talk to us, as well as everything you do for your patients, especially the VHL community. It means so much to us, and thank you again for joining us.
Really, my pleasure. Thanks again, and I hope to see many of you soon. We are not closed for coronavirus, but we are sort of paused and ramped down. But we look forward to seeing many of you soon, either via telemedicine visits or in person over the summer.
Thank you. And for everybody watching at home, I invite you to join us for more events in the Surviving and Thriving Together series, which you could find at vhl.org/together. Thank you for tuning in, and until next time, stay safe. Thanks again, Dr. Ball.
Thank you.